Good afternoon, everyone. I'd like to welcome you to the Luncheon Symposium. We'll start in about 5 minutes. Just feedback.
There's feedback, there is.
There's quite a bit of feedback.
There was feedback. Oh, wait a minute. Can you hear mine? No. It was on for a second. That was weird. It was on. Like, I think they're... I hope they don't turn on Sandra's. 85 minutes? 85 minutes. So an hour and 15 minutes. Oh, so it's supposed to be 11:45 probably, right? Like, yeah. Because if we do 11:45, then we've got an hour and 15 minutes. Oh, is it 12 to 1? I thought it was 11:30.
Good afternoon. Good afternoon, everyone. Welcome to the symposium entitled Neurobiology of Appetite Regulation. My name is David Lau. I'm very honored to chair this exciting symposium. I'm an endocrinologist and a professor of medicine at the University of Calgary. We have a very distinguished panel of speakers joining us this afternoon to share their insights with us. This is a very unique symposium in that we also have a person living with obesity who will be sharing with us her personal journey with obesity. Before we start, here are the disclosures for all the speakers and myself. And the objectives of this symposium are listed on this slide. After participating in this session, participants will be able to explain how the brain controls appetite and protect the body against weight loss. describe the clinical evidence on how pharmacology supports patients in appetite and weight management, and discuss the role of behavioral therapy and motivational support in weight management. This is an interactive session, so we hope that you'll be able to log onto the website. So for those of you with smartphones, I'm sure all of you all have already taken advantage of the Wi-Fi, and if you haven't, the Wi-Fi is Western Conference, and the password is 6COS. You can either use the QX code, which is on your table, scan it, or you can go directly to the browser, www.slido.com/Ottawa, or if you have the Slido app, the code is Ottawa, and that will take you directly to the polling questions that we'll be asking you, as well as where you can pose the questions to all of us. So there's a button on the questions that you'll see on your browser once you've logged on to the slido.com. And please remember to complete the evaluation after the symposium. So without any further ado, it is my honor and pleasure to introduce Sandra Elia, who is an award-winning motivational speaker, a certified food addiction counselor, and she will share with us her journey with obesity. So please join me in welcoming Sandra.
Thank you. Thank you. I'm going to share my story of living with obesity, overcoming obesity, and what it's like to live with this chronic and complex disease. I've lived two lives. One as a woman living with obesity for 15 years, trying to navigate a world not made for her size, seeking medical treatment, and experiencing the emotional distress that affected my relationships, my career, and my well-being. And I've lived another life at a healthy body size for the last 15 years, and I can speak to the dramatic differences in how people relate to me at this size. And now I sit on the other side of the desk as a healthcare provider for people living with obesity. So my story begins, and actually, my story begins like all stories begin, at conception. My mother, when she was carrying me, was living with obesity and bipolar disorder. My childhood set the stage for developing obesity. I experienced childhood trauma, neglect, and compulsive overeating was modeled to me at a young age. I didn't start gaining weight, though, till my pre-teen years. And then I spent my teen years desperate to be thin. Diet after diet, dieting my way into obesity. And at the age of 20, I went to my doctor for help. And she said, calories in, calories out. And I don't think she understood how I internalized that message. I felt stupid. It seemed so simple, and yet it was something that I could not grasp. And as the years went on and I continued to gain weight, the shame and embarrassment of that kept me away from the doctor for all health concerns. Then, in my mid-20s, I landed a job at an international consulting firm. It was my chance to work on Bay Street, so I hired a Bay Street weight loss expert. And I somehow managed to stay on a restrictive diet for 6 months, and I lost 50 pounds. I also managed to kick in the starvation mode in my brain, and after every famine comes the feast. My rebound not only included regaining those 50 pounds, but an additional 50 pounds. And that was the most humiliating experience of my life, showing up month after month, heavier and heavier at work. And I wish that I could tell you that it was only my eating and my weight that was out of control. but obesity touched every area of my life. My marriage was breaking down, my family relationships were strained, and I was on extended sick leave from work. I did manage to gain control, and I did manage to lose over 100 pounds. I did this by identifying as a food addict, and I eliminated trigger foods. Trigger foods are foods that I obsess about, foods that once I start eating, it's very difficult for me to stop, and generally these are ultra-processed foods. I went on to seek counseling for my marriage and the trauma that I had experienced. I developed a mindfulness and spirituality practice. I began exercising, and I enjoyed weight stability for 6 or 7 years. And it was a good time in my life, filled with adventure, travel, living abroad, dating. Things were very good. I did experience 2 other relapses, one spurred on by going in another restrictive diet, and another one by a stressful life event. But today I'm in a place where I've regained control, and today at 46 years of age, I'm seeking medical treatment for obesity again, 25 years after my original attempt. Why? Why when things are good? Because I don't want to struggle anymore. I want to set myself up for success. I want to be preventative, and I really believe that we're at a point in history where we have viable, evidence-based treatment options that work.
Thank you very much, Sandra. So before we go on, there's a polling question, so I hope all of you are able to get onto the slido.com and vote by pressing A, B, or C. So what is the most common reason for weight regain? Not being able to maintain a diet, not enough time for exercise, or not being able to resist cravings. So please vote. All right, so you can see on the screen, okay, so that's a very good start for the next presentation, which will be given by Dr. Rodger McIntyre, who is a professor of psychiatry and pharmacology at the University of Toronto. He's also the executive director of the Brain and Cognition Discovery Foundation. And Dr. McIntyre is a highly sought after speaker and was named by Reuters Thomson as one of the most sought after scientific minds of the world. Unfortunately, Rodger can't be here in person, so he's going to be talking to us via a videotape, and his talk is on body-brain connection in weight management. So let's roll the...
Well, thank you for that introduction, and good day to everybody, and greetings to all attending the Canadian Obesity meetings. I'm sorry I can't be there in person. It is a delight for me as a psychiatrist and as a neuroscientist to share with you really the latest science as it relates to the central nervous system and obesity. And what I'd like to share with you is, in fact, 3 interrelated points. First, we now know that obesity is a consequence of 3 interrelated disturbances in the brain. Those areas I'm going to refer to over the next 15 minutes or so is disturbances in homeostasis, hedonism, and executive function. I call that the troika of obesity. Secondly, we're going to talk about the bidirectional relationship between the brain, the central nervous system, and obesity. And this is an area that has not just captured the attention of folks like me in neuroscience, but also translates in what we're trying to do clinically for people affected by obesity. And thirdly, how does this information, the so-called troika of homeostasis, hedonism, and executive function, and the neuroscience behind it, how does this help us guide treatments, and how can we provide the best management approaches for people suffering from obesity? Let's begin, if we can. The central nervous system is comprised of discrete circuits and networks. And what we now know is that several of these networks and these circuits subserve key aspects related to weight and obesity. I'm focusing on homeostasis of eating. We're talking about the hedonism or the pleasure and motivation around eating, as well as the so-called executive functions. Now, in the world of neuroscience, executive functions encompass about a half a dozen different responsibilities. Two of those responsibilities are the initiation and the inhibition of behavior, including but not limited to eating. What we know is under normal circumstances, humans engage in normal eating patterns as a function of this troika activity, that is homeostasis of the appetite and satiety centers, the absolute right balance around motivation and reward, so-called hedonism, and also the control of eating, which is in fact overseen by executive functions. Let's talk, if we can, a little bit first about the homeostasis. The homeostatic processes that are subserving and mediating normal and abnormal weight states are well characterized not only in animals, but also in humans. All of the attendees at the Congress today are fully aware that the signals that regulate the homeostasis of eating under normal and abnormal circumstances are not only in the periphery with well-known peptides like leptin, which reduces appetite, and ghrelin, which increases appetite, but also central peptides, one of the best characterized being the POMC, the peropial melanocortin peptide, which creates cleavage products which both can stimulate and or inhibit appetitive behaviors. Perhaps one of the best characterized anti-appetite peptides is alpha MSH, and one of the best characterized pro-appetite peptides is the opioid-ergic system. Just parenthetically, as a clinician, I not infrequently prescribe opiates, and we well know that in animals and humans, opiates stimulate appetite. The converse is true. The blockage of opiate systems seems to assuage or reduce the craving for certain foods. More on that in a moment. Let's say a few words now about executive functions. As I said, executive function is plural. There's about a half a dozen different functions that are subsumed under this banner called executive functions in the brain. Two of those functions are the initiation and the inhibition of behavior. Behaviors including, but not limited to, feeding. We have many examples in psychiatry where people have a disturbance in executive function, and associated with that is chaotic eating patterns. One of the best examples of this is children and adults who have ADHD, attention deficit hyperactivity disorder, which is a quintessential executive function disturbance. We know people with ADHD, both pediatric and adult, have significantly elevated rates of obesity if they're not treated. Interestingly enough, if we can reset their executive functions, which we do with stimulants, we can actually bring their appetite and feeding behavior back to normal. It's a great illustration of how executive functions gone wrong can lead to obesity, and when corrected, can in fact reduce obesity propensity. Let's, if we can, now shift into the third area called hedonism. Now, hedonism in psychiatry is often referred to as anhedonia. Anhedonia is not a unitary construct. In other words, it's not a single entity. It's comprised of different entities. We like to break anhedonia or hedonism into two separate but related parts: motivation and reward. What's often referred to as really the wanting and the liking. And these are related but different constructs. Under normal circumstances, we would want certain nutrient, and that nutrient would have a certain level of pleasure. Under abnormal circumstances, the motivation around eating becomes abnormal, as does the reward experience that accompanies feeding behavior. One of the great insights we now have in neuroscience as it relates to obesity is that people who are prone to obesity and or people with obesity exhibit profound abnormalities in the brain in circuits that subserve motivation and reward. So it literally is a brain disease that is leading to obesity. What's really concerning is that once a person has obesity, through the process of inflammation and insulin resistance, what happens is that the obesity causes even further changes in the brain, further dampening down motivation and also further altering reward systems. A great example of this is illustrated on the slide next to me. We have 4 discrete dopamine circuits in the brain. Relevant to today's presentation is the reward circuits, notably in the mesolimbic and the mesocortical system. We know that these systems are relevant to motivation, relevant to how we value a certain reward, and also to some extent how we enjoy a particular experience. In the brain of people who have obesity, there's not only an alteration in the neurochemical signaling of dopamine in these 2 and other brain regions, but there's also something wrong with the structure and the function of these circuits. Lots of research now has been done looking at the brain in 2 ways. We can look at the structure of the brain, and we can look at the function of the brain. That is the functional interconnectivity involving circuits and networks subserving homeostasis, hedonism, and executive function, the troika. And in keeping with the view that obesity is a brain-based disorder and also obesity affects the brain, we have highly replicated and convergent evidence that obesity changes the structure, the function of circuits within these areas of homeostasis, pleasure, motivation, and executive function. We've recently published a large review of this literature looking at the brain and more specifically what we call the connectome. In other words, we know the brain's comprised of circuits and networks, and when we look at the connectome, how these circuits and networks are connected in people with obesity, we see changes. These are not random changes. These are changes in brain that are subserving this important aspect about regulating food intake and satiety, regulating the motivation towards the food or away from it, regulating the reward experience, and also this executive function that is the initiation and the inhibition of that behavior. We know that obesity is a highly heritable trait. In fact, most heritability estimates would suggest that the heritability of obesity is as high as 50 to 70% in some studies. This report, conducted in neonates only 2 weeks old, indicates that neonates who are born to moms with obesity also exhibit changes in those exact brain circuits subserving homeostasis, hedonism, and executive function. This is an intriguing study because it speaks to the heritability of obesity, but also particularly intriguing because it speaks to the transmission of the neuroscientific alterations in the brain that are leading to obesity downstream. What's become particularly concerning and disquieting to us is that along with circuit changes, when we narrow our regions of interest and look at a unit of analysis, a more refined zooming in, so to speak, we find evidence that the brain is aging in people who have obesity. Premature aging has now been described in obesity. This has been looked at in this study, which is an artificial intelligence machine learning approach, comparing the age of the brain amongst people with obesity compared to healthy controls. On average, people with obesity are about 2 to 4 years older from a brain age perspective. FEP refers to first episode psychiatric illness. They also have brain aging, and indeed 1 + 1 = 2, sometimes equals 5. And in this study, what we're seeing is at least an additive effect of psychiatric illness and obesity on the brain. More recently, we published a study looking at postmortem brain in people with obesity. And to keep this brief, what I will say is what we found in our genetic analysis looking at the brain is we found alterations in genes that are responsible for the homeostasis of eating, the hedonism of eating, like reward, particularly in the area of inflammation and dopamine, and also in executive functions. And executive functions are regulated by dopamine and by insulin. So interestingly, at the circuit level, right down to the genetic level, we see changes in systems that we are knowing subserve these 3 aspects I'm calling the troika. Everyone in attendance today knows that people with obesity have higher rates of select mental disorders and vice versa, such as major depression, some anxiety disorders like PTSD. I already mentioned in passing ADHD as well as binge eating are just a few. It's not by coincidence this is happening, because the brain substrates that subserve homeostasis, hedonism, and executive function are also the exact brain substrates subserving many mental disorders. That is why these conditions overlap. We have a paper that's under review right now where we've looked at people with major depression, and by definition, many people with major depression suffer from deficits in reward experiences and motivation. And what we found is that amongst adults with major depression who are overweight or with obesity on the far right, they exhibit even greater deficits in reward and motivation. Said differently, depression decreases motivation and reward, so does obesity, and the two together have a multiplicative effect on this outcome. Finally, what does this information tell us about treatment? Well, what we want in treatment is treatment that can correct the circuit alterations as well as the neurochemical alterations. This is a study where people with obesity were given naltrexone bupropion. And that treatment over a period of time resulted in a corrective effect on the exact circuits we're implicating in homeostasis, in hedonism, and executive function control. Okay, so where does that leave us? First of all, just to briefly summarize, there are three areas of phenomenology that we believe relate to normal and abnormal weight management, that being the processes subserving homeostasis, the processes of hedonism, and executive function. Secondly, we know when there's alterations in the brain systems that are subserving this phenomenon, that could result in obesity, and also a vicious cycle could be created wherein the obesity can metastasize back to the brain and progressively disrupt these systems. The promising aspect about this is that we have multi-modality approaches that we believe could exert favorable influence on this process. In other words, we could break this vicious cycle and turn it into a virtuous cycle. In other words, get people back on the right track. One way to do this is through, in fact, sleep normalization. Sleep normalization has been shown, in fact, to correct some of these systems subserving homeostasis, hedonism, and executive functions. Secondly, behavioral approaches in terms of a more regular eating pattern, a more healthy eating pattern, has also been shown to correct many of these, what I call aspects of the troika. We know that some patients are candidates for bariatric surgery. Recently, our team published a large systematic review showing that bariatric surgery not only causes significant weight loss for many candidates, but also, in fact, benefits significantly aspects of homeostasis and hedonism, as well as particularly their executive function. And finally, let's not forget about pharmacotherapy. And pharmacotherapy historically has targeted a dimension, this one or that dimension, but the current conceptualization of brain science as relates to obesity suggests that the more we can target these multiple systems, that being homeostasis, hedonism, and executive functions, the more likely patients will be successful at achieving the therapeutic objectives in weight management. Thank you for joining me for today's session.
Well, thank you very much, Rodger, for making very complex neurobiology into a very simple message of the troika. So before we go to the next section on the pharmacotherapy and how that supports appetite change and weight management, I'd like to invite Sandra back to share with us her journey.
So my journey with obesity and weight loss was built on two pillars. One of these pillars is mindful resistance, and the other one is resilience. So it really never mattered what plan I was trying to follow or what diet I was embarking on. My real struggle was with cravings. And for me, cravings are intense, immediate, and overwhelming. And so for a good portion of my life, I was a professional dieter, which meant every Monday morning I would start on a new diet. And by 2 p.m., I'd have my first craving. And this would ensue a mental tug of war. Will I, won't I, will I, won't I? And the only thing that would quell that was to give into the craving. Giving into cravings on a consistent basis really chipped away at my self-esteem and my self-confidence. in believing that I could ever sustain a healthy lifestyle. What I didn't understand at the time was that living with obesity and having lost a significant amount of weight had affected my brain, that I respond to food cues in a more dramatic way, in a more intense way than someone who's been weight stable for their whole lives. And if that's not enough of a disadvantage, when I eat, I don't get the same satisfaction. So the problem never was about knowledge. It wasn't about what to eat or what not to eat, but rather how to stay calm and confident in the face of a craving. And when the resistance failed, and of course it would, I had to move over to resilience. And the quicker that I could bounce back, the better it would be. Having suffered several relapses, I've learned that coming back is immensely difficult. It seemed as though the cravings had been revved up, that the eating became more erratic, more episodes of uncontrolled eating with restrictive eating, and that my eating wasn't driven by hunger. And sometimes the mere act of eating, even a healthy, well-balanced meal, would ignite this hunt, this desire, this wanting for more. So today I use behavioral modification, CBT, pharmacological therapy to really bolster up these two pillars of resistance and resilience. So if in the past I would classify the intensity of a craving as a 10 out of 10, today it's more like a 5 out of 10, a 6 out of 10. It's more manageable for me. I'm experiencing food cues in a less triggering way, and I'm finding eating more satisfying. I feel as though for the first time in my life, I'm experiencing food and eating the way it should have been, the way it could have been had I not developed obesity. The behavioral modification, CBT, and pharmacological therapy helps me with the resistance as well. Recovering from a setback that would normally take days, weeks, months, now I can almost do that the next day. And it alleviates a fear of being hungry, which sounds ridiculous in the world of Uber Eats. But that really drove a lot of my decisions. Oh, I better have a little more at lunch so I can make it through to dinner, and I better make sure dinner is substantial so I don't eat before bed. And now I feel confident to let go of those extra calories. And the biggest impact in my life is that it has freed up so much of my mental real estate so I can focus on things that are very important to me.
Thank you, Sandra. So here's a polling question that I'd like all of you to vote on. What is your perception of pharmacotherapy for chronic weight management? Isn't it cheating? Or is it a good option when everything else fails? Or in any case, it's a good option as part of a comprehensive plan for weight management. And some of you will say, well, I'm concerned about side effects and the cost. So please vote. Wow, wonderful. Okay. So now let me introduce the next speaker who really needs no introduction. Dr. Sean Wharton is well known to you all. Among his many other hats as not just an expert in obesity, but he's now also the co-chair for the 2019 Clinical Practice Guidelines updates on the management of obesity in adults. Dr. Wharton would talk about the pharmacotherapy for weight management. So please join me in welcoming Sean.
Thank you. Thank you very much, David. Thank you. This setup has been great. What Rodger has been able to talk to you about and what Sandra has given you from a real perspective is going to really help with what I have to say. So the hope is that what you can do is you can take away from this something significant that you can do differently, and particularly the way you speak to your patients and the way you think about the treatment options. So this is another graphic depiction of the brain and how we think that obesity currently has an impact. So we know that there's two main parts of the brain that are causing the major issue. So the hypothalamic, the homeostatic hunger. So everybody, if you decide you're not going to eat lunch today, in a little while you'll get hungry, and that's the hypothalamic area. Every time you go on a diet, you have no option but to get hungry. The issue is, can you manage that hunger? Because that's the only way to keep the weight off. So you have to manage the hypothalamus. Next is the hedonic mesolimbic component. So this is the craving. This is past the hunger. I've already relieved my hunger, yet I want to eat more. This is the hunt. This is why people are sitting near the dessert section or other types of things like that, because you're hunting for that necessary food. These parts of our brain, which are driven by these hormones here, were the first part of our brain to develop. You can't beat them. There's no way to get rid of this part of the brain, or else we all wouldn't be here. We wouldn't have made it. So if it's overactive, particularly when you go on a diet, you've got to calm it down. How are you going to calm down those hormones? The two ways to do that is bariatric surgery, which cuts out ghrelin and increases some of the other hormones that are the good hormones that calms down that part of the brain, or medication that gives you back the hormones that you're missing, or eventually will be blockers of the bad hormones. So those are the two ways to calm down that hedonic hypothalamic part of the brain. The other way that we have some control over this is our frontal lobe, the executive functioning. If you can wake up that executive functioning in the light of the fact that hunger is happening or hedonism is happening and you'd like to stop it, then you have to have that frontal lobe section awake and working and cognizant, which is where the word cognitive behavioral therapy comes from. If you're not aware of what's going on, you can't beat it. So psychological treatment is cognitive behavioral therapy, and that's how you wake up the frontal lobe. So this is probably the most important slide that I have here. This is from my friend Mark Cornier. He's a neuroscientist in Denver. So what he looked at was where in the brain do we get lighting up in thin subjects versus weight-reduced subjects. So everybody here is on a diet, and as a result of being on a diet, these parts of their brain are lighting up like crazy. And how are they going to maintain their lower calories if these parts of the brain are driving them to eat more food and have excess hunger? It's going to be very hard. So every single time Sandra went on that diet, these parts of the brain were lighting up. No way to use willpower motivation to stop it. They're ready to go. So you have some options here. You either have to calm them down, or you have to have a strong enough executive functioning, a big army, to be able to battle those. That's the treatment. So, and these are the parts of the brain that we actually look at that are lighting up. They're the reactivity sections, the regulation section, the evaluation section. So we have a lot of areas that are actual triggers. So, so what we know about medication, if we want medication that are effective in this brain neuroscience chemistry, is we need smarter medications that work in the right areas. What are those right areas? The hypothalamic area and the mesolimbic area, and potentially the executive functioning area when we eventually get medications for that. We need to increase our research, because that last slide showed you the multiple areas. Right now we have some medications that work in certain areas, but not all of the areas, which makes it challenging. So we need more research into this field of neuroscience. So here are the medications that we currently have on the market here in Canada. So we can see that one of them is a peripheral medication. The other two are central. Central meaning working in the brain. And as I just said, the smarter medications are the ones that are working in the brain neurochemistry. So let's look at liraglutide 3.0. What we know about this from the product monograph and the way that we've been researching it is that it goes to the hypothalamus, the homeostatic area. So when you start to lose weight, you'll get hungry. You use this medication to stop the hunger, hypothalamus. So, and it obviously works. But we also know that new research is coming out showing us that these GLP-1 analogs are working not just in the hypothalamic area, but in the hedonistic mesolimbic area also. And that would be part and parcel of why it's actually working. So if it didn't work in that hedonic area, there would be a major challenge. It may not work quite as well. So more research is actually coming out with that. So we see weight loss with the medication likely because of the interaction both in the hypothalamic and the mesolimbic area. What we see in the product monograph for Contrave is that it works in the hypothalamus area because the way that the bupropion component works, releasing alpha MSH, going to the MC4 receptor in the hypothalamus, decreasing hunger. But it also works very well in the mesolimbic area, that craving area. And what Rodger just told you is that we are seeing that this medication is allowing a connectivity. So Dr. Wang has done a lot of research in this, looking at the fact that you're connecting the mesolimbic area with the frontal lobe. So the frontal lobe now has control over that hedonistic mesolimbic area. So that is another thing that we're learning more and more as to why the medication works. So we see here from the actual research study that regardless of whether you knew it was working in the brain or how it was working, weight loss is actually happening. And it's likely because of those areas. So what many of my patients ask me is, with this medication, how much weight am I going to lose? And the challenge is I don't know. I always say to them, I'm not sure. I don't know. The average is about an 8 to 10% weight loss. But that's an average. It means that there's people on the other side that didn't lose very much weight. There's people who lost a lot of weight with it. So I'm not sure where you are going to fall. Will you be someone who loses 15%, 20% with the medication, or loses 2%, 3%? The only way to know about this is to actually try. So the more research we do, we may be able to pinpoint what patients are going to do better on which medications. But what we do know is when we talk about this as a 5 to 10% weight loss with these medications, about an 8 to 10, is that enough weight loss? So, and many people may say 5% isn't all that much. But what we can see is 5% drives blood sugars down in a significant fashion. Diabetes is one of the most significant medical conditions that we know of. Just a 1 kilo body weight loss, which is 1%, decreases your relative risk of developing diabetes by 16%. That's a big deal. So if we think about 5%, is 5% a big deal? If everybody could get 5% more of their yearly income right now, would that be a big deal? Probably, right? So I think that 5% works. So we have to think about that. But what we do know is that whatever weight management strategy we are actually using, if we stop that strategy or stop all the strategies, the likelihood is the weight is going to come back. And so the mindfulness and the willing and the willpower doesn't end up giving us long-term weight loss. Another way to actually look at this is to think of the fact that the only way to lose weight is lower calories. And the only way to keep weight off long-term is to maintain those lower calories. Think of the lower calories as the roof of a house. So the roof of the house is here, and the way to maintain those lower calories and the activity and the good self-esteem are 3 methods: medication, surgery, and psychological treatment. You can do one of them, you can do all 3 of them. If you're going to stop one of them, switch to another one. But if you stop all 3, you will regain the weight as on that previous slide. Okay, and psychological is food addiction or CBT therapy. So what we do know is that we've talked about the 8 to 10% weight loss. Are we going to get more weight loss, or are there adjunct therapies? Because we talked about the watershed plot, which showed some people losing weight, most people losing weight, but some people not. So the question is what else is there? So are there going to be other adjunct therapies? There are a ton of them. So we're really looking into a lot more research to determine which other medications we can have to have adjunct therapies the same way we do with diabetes. We don't have one medication diabetes, we have about 30. And so this is the direction we're going, where there's lots of actual hope. And what I really feel strongly about is that when we have medication, I believe you need to strengthen your executive functioning. The medication only gives you the ability for your executive functioning to actually win, to have a fighting chance. It gives that army a fighting chance. So if you're not doing cognitive behavioral therapy, then it's a bigger challenge. So we know that we have physicians who are doing cognitive behavioral therapy. Sandy Van is doing this in Toronto, so I refer a lot of my patients there. And Sandra Elia doing a component of cognitive behavioral therapy in the food addiction world. So, but what we do know is that if you think about pharmacotherapy, how many people are actually interested in it? This study, the action study that David Macklin did, took a look at the fact that only 3% of patients think that pharmacotherapy is effective, and only 17% of healthcare professionals think it is an effective treatment. This implies bias. It implies that they don't believe that it's a medical condition. Would it only be 3% if it was diabetes, hypertension, or breast cancer? Of course it wouldn't be. It would never be 3%. The only reason this is 3% is because of implicit bias. And what is bias? So 2% of people are on anti-obesity medicine so this is a dismal number, when this is an effective treatment option. Again, it's because the belief is that you don't need it, the belief is that it's cheating, the belief is that there's no understanding of the pathophysiology of where it acts in the brain. So the takeaway message is that pharmacotherapy is effective, particularly when in combination with cognitive behavioral therapy, psychological therapy that wakens up the executive functioning. So I believe that the medications that are going to be effective are the ones that work in the brain to either increase the executive functioning or to dampen that hedonic mesolimbic hypothalamus hunger areas. And we know that pharmacotherapy is scalable. It's the one treatment that we really, really have that we can give to lots of people. So therefore, I think we're in a position where the future is a lot brighter. Thank you.
Thank you, Sean. So before we go to the last segment of the symposium on behavioral therapy, let's have a vote on this polling question. Do you recommend or consider behavioral therapy for sustained weight management? Yes or no? Wow, we're preaching to the converted. Okay, all right. So Sandra's going to talk to us a little bit more about her ongoing journey, and this will then be followed by our last speaker I'll introduce in a moment.
So my journey began from what might seem like a counterintuitive place. I really didn't care if I ever lost another pound again. I had to let go of the scale. That number never made me happy, and I was never able to control that number. What I could control was my behaviors and my perspective. So today, I always say my weight is none of my business. My business is to live my best life, and wherever my weight ends up, it ends up. And I need to make peace with that. Because in the past, when I had self-loathing and harsh judgments about my weight, it drained me of every ounce of energy and motivation I had to change. So I had to begin this journey from a place of self-acceptance and self-love so that I could have the courage and the strength to put this village together. My village includes a physician, but that is just one piece of the entire puzzle. I had to find new ways to measure success. I had to have a sustainable meal plan. I had to work with a counselor. I developed mindfulness and spirituality. I had to begin exercising in a safe and fun way and be tapped into community support. In the beginning, these interventions can seem very overwhelming, but as time goes on, it becomes a way of life. And it does attract a lot of joy to my life. So I'm going to pass this on.
Thank you. I'd just like to encourage everyone to put in the questions through the smartphone so that we can talk about that at the end of the presentation where we have a panel discussion. And it's my pleasure to introduce Dr. Dayna Lee-Baggley, who is a registered clinical psychologist and an assistant professor in the departments of family medicine, surgery, psychology, and neuroscience at Dal. So without any further ado, Dayna's going to share with us her perspective on behavioral therapy.
I
everybody hear me? Is my mic on? Okay, awesome. All right, so I'm going to invite you to a challenge, which is that tomorrow I would like you to weigh 245 pounds. The day after that, I would like you to weigh 127 pounds. And the day after that, I'd like you to weigh 301 pounds. How do you guys feel about that? Could you be able to do it? Would anyone be able to do it? Okay, how about this one? Tomorrow, I'd like you to drink 2 glasses of water. The day after that, have a cup of vegetables. And the day after that, go for a 10-minute walk. How are we feeling about those ones? Doable? Right. So what's the difference? Okay, the difference is what we control. And there's lots of evidence that we don't control our weight. Right? There is a cultural myth that we actually, if you just try hard enough, you'll be able to control your weight. But as we can tell from all kinds of ongoing research, that there are numerous factors that influence weight, most of which we have 0 control over. So even though we can influence our weight, we don't have one-to-one direct control over it. What we do have control over is our behavior. Okay, so behavior is something that's observable, measurable, and under your direct control. And so when we set weight as the goal, we inevitably run into problems because we don't have direct control over that, right? So often what will happen is you're exercising, you're watching your calories, and the scale's not moving. Well, if weight is your goal, then why on earth would you keep doing all these things when it's not impacting your weight? So you naturally would stop doing those things. Let's say you're successful at it and you do lose some weight. Okay, well, what do we do when you achieve a goal? What do? We celebrate, maybe with an ice cream sundae, and then we move on to another goal. Okay, so the way we understand goals in our culture is that once you've accomplished it, you move on to something else. So even if you do achieve some kind of goal with your weight, the natural response is then to move on and stop doing all the things that got you there. And so that's why it can be problematic to set weight as your goal. If we set behaviors as our goal, then we have a lot more control over it. If you try harder to lose weight, you might actually gain weight, right? We actually know the stress hormone, for example, can actually cause you to gain weight. If you try harder to eat green vegetables, you're more likely to eat green vegetables. So setting behavioral goals is the part that you control, okay? And that's something that Sandra basically came across in her journey. So we can help patients move faster along that journey by helping them understand these principles. When you're setting behavioral goals, 2 little things to keep in mind. Pick the do instead goal rather than a don't do goal, and pick the 90% goal. So I'll explain what I mean by that. So just for like 10 seconds or so, I'm gonna ask you to not think about pink elephants. Don't think about pink elephants. Don't imagine pink elephants. No pink elephants. Everybody okay with that? We'll just, 10, 15 seconds. Just don't think about pink elephants. Okay, did anyone happen to think about pink elephants? Or have to work really hard to not think about pink elephants? And were pink elephants like a big topic of conversation? Everybody over at the coffee station, ooh, pink elephants, or like it's trending on Twitter? No, probably not, right? But the minute I tell you not to do it, now you're thinking about it. And this is a well-established principle in psychology called the thought suppression effect, that the more you try to not think about something, the more you think about it. And what do people do when they try to manage their weight? They decide what they're not gonna eat. Right? I'm not gonna have pop, I'm not gonna have chips, I'm not gonna eat white things, I'm not gonna eat bread. And basically, we're creating pink elephants. So rather than setting a don't do goal, set a do instead goal. What are you gonna do instead of eating chips at night? What are you gonna do instead of having pop at dinner? Okay, the 90% goal is about setting an achievable goal. So to only set something that you are 90% sure you can achieve. Okay, when we do this, we actually start to feel success, right? If you pick something you're gonna be successful at, then you wanna keep going. When we continuously fail at something, we just stop trying. That's just human nature. So pick things that you're 90% sure that you can achieve, and then build from there.
So for me, identifying my values was a game changer. And I hold 2 values near and dear to my heart. One of them is to be a high-performing person, and another one is to be a really great mom. So In terms of being a high-performing person, when I'm compulsively overeating, that really robs me of energy, happiness, health, time, my goals. I show up in the world very differently. The world responds to me differently. And eating compulsively comes with a big price tag. It's an emotional, mental, and physical price tag. In contrast, when I'm living my healthiest life, my best life, that allows me to be creative and positive and energetic. And that attracts wonderful opportunities to me and beautiful people to me. The other value is being a really great mom. So I have an 8-year-old daughter, and she rarely listens to a word I say or does a thing that I ask, but she's watching me. She's studying me. And if I want her to grow up loving her body, filled with confidence, making her health, her happiness a priority in her life, the only way that I can teach her that is to show her through my own actions.
Okay, so healthy behavior, pretty much anything you're going to do to try to manage your weight is going to suck. Okay, so, the human brain, caveman times, right, has been shaped by evolution to seek pleasure, to avoid pain, to do the thing that takes the least amount of effort, and to live for today. Those are excellent principles if you are a cave person. Very helpful. Healthy behavior, on the other hand, requires us to avoid pleasure, no, don't have that ice cream, to accept pain, go for a run, do the thing that takes the most amount of effort, take the stairs, not the elevator, and live for the future. Don't you know that might kill you in 20 years? So basically, healthy behavior is abnormal. And if you start from this place, that healthy behavior is actually abnormal, then it makes a lot more sense as to why most people don't do it. Right, so what's going to feel better, apple pie or apples? Apple pie is going to feel better. Your brain is hardwired to react to the sugar in it. It's going to light up better than it does for cocaine, right? Okay, so rather than trying to convince people that healthy behavior isn't that hard, instead, what we want to do is help them figure out what's going to make it worth it for them to do it. So instead of asking what's the matter with you, we should be asking what matters to you. What's going to make it worth it for you to do this hard work? And Sandra has this lovely description of her values and what makes it worth it for her to do the hard work of being healthy. Okay, so values are about, who you really want to be in life, the kind of way you want to show up, the kind of person you want to be, what really matters to you. And Sandra has these lovely descriptions of the values that matter to her. Hey, values are like a direction. So again, our culture is very obsessed with goals. Goals are things that happen or don't happen. Values are more like the direction that you take. So if it's important for you to be a kind and loving person, there's a couple things about that. Every step you take, every time you show up that way, it counts. And you also never get there. You're never done. So I can't say, you know what, in 1989, I was super nice to my sister, so I'm good. Right, if that is a value that matters to you, you have to keep showing up like that over and over again. Okay, so often we ask people, why do you want to lose weight? And common answers are to be healthy, to have more energy, to be more active, to live longer. And the next question that we don't ask, but we should, is, and what are you going to do with that extra energy? What are you going to do with the extra years of life on Earth? What's going to make it worth it for you to do the hard work of being healthy? Okay, so what we're looking for are reasons that are personal and meaningful, related to their identity and their values. We're not trying to make health more important. We're trying to find something that's already important to them and link their health behaviors to that. So Sandra has this lovely description about the fact when she, puts good food in, when she's exercising, that actually helps her show up as the way she wants to show up. So for example, you might have the value to be an engaged parent. And what we're trying to help people see is that going to the gym isn't me time, it's not selfish time, it's actually helping you show up as the parent you want to show up as. It's actually helping you be the parent you want to be. And basically what this is doing with the values work is trying to activate the frontal lobe. We're trying to activate that in a conscious, deliberate way to figure out what's going to make it worth it to do this hard work. And some studies in terms of managing weight, acceptance and commitment therapy is a type of CBT that incorporates value. So it's one of the main pillars of that intervention. And what we can see in this slide is that CBT and ACT are pretty similar at post, but there's this trend towards perhaps longer term change. We actually don't have the data yet to know if that's true. But it would make sense given that the intervention itself is focused on values and helping people identify their values. So it might suggest it might help with longer term change.
So when I look back on my journey, one of the biggest lessons I learned was when I was striving for perfection, I was going to fail each time. I really believed that when I started on a journey that I was going to start at point A and it was going to be smooth sailing onto my goal, no detours, no mistakes. And that's just not the human experience. And that progress really looks like 3 steps forward, 2 back, 2 steps forward, 1 back. And the way that I treat myself during a setback was actually going to determine whether I got to my goal or not. And in the past, I had this belief that every time I messed up, if I took out that shame stick and I just beat myself up hard enough, long enough, I would never do it again. And nothing could be further from the truth, because that harshness often drove me to seek comfort in food. So when I messed up, I really had to flip the switch. That had to be the time that I practiced the most self-acceptance, the most self-compassion, because in that environment, I could keep going. I started to realize that whenever I made a mistake, I would spend a lot of time, energy, analysis, rumination on that mistake. And when I had a success, I would spend a moment or two and move on with my day. And I began to believe that my successes deserved the same amount of time, attention, rumination, analysis, cementing it into who I am and who I was becoming. And I was reaffirming that I was becoming stronger, it was getting easier, and I was becoming healthier.
Okay, so again, Sandra does this lovely job of describing, right, what people think success is going to be like and then what it actually is. And so, it helps us to let people know that that's actually what it's going to look like, that it's not going to be a straight line. Right? So it's not really a question of if you will fall off the wagon. The question is, how quickly can you get back on? Right? All the behaviors that are necessary to manage weight are in fact very complicated behaviors, right? They involve all kinds of different things that you need to do. And given our world, which is full of cues for unhealthy behavior, it's really just a series of falling off the wagon and getting back on. And what we know is that when people are kind and compassionate to themselves, there's actually lots of literature on this, that when they can be compassionate with themselves during those personal setbacks, that they're actually more likely to persist. They actually get back on the wagon faster. Right? So people don't change when they feel guilty, when they feel ashamed. People change when they feel good about themselves, when they feel supported, when they feel like they have the confidence to keep going. And so healthcare providers can actually also help with this process by having a stance of non-judgmental, kind, compassionate curiosity, and to support the fact that it's really normal to fall off the wagon. Your job is just to get back on as quickly as possible and to be kind and compassionate, because really you are just being a normal human. And if you were a caveman, you'd be our ancestor. So our takeaway message is to choose behavioral goals, things like walking, instead of outcome goals like weight, to link your behavioral goals to your values, things about your identity or meaning, to be able to answer the question, what will make it worth it for you to do the hard work of being healthy? It's not a question of if you'll fall off the wagon, it's how long does it take you to get back on. And being non-judgmental and compassionate is more likely to foster change and persistence.
Terrific. So thank you very much to all of you for your presentations. There's quite a few questions that I see on my iPad, so please keep the questions coming. So the first question is to both Sandra and also to Dayna. How does spirituality help with weight management? And are there any studies to support the notion of spirituality would actually help?
So for me, I believed that addictive eating was mindless eating. And so one of the antidotes for me was to become more mindful. And the spirituality portion of it was really trying to connect to who I truly was. And it was an attempt to repair the damage that obesity had done to my self-esteem and my sense of self-worth, and really identifying to a place inside of me that I believed was whole, that was well, that, that divine spark that I was born with, and trying to live a life from that place. So that's the way that it helped me.
Yeah, so there's, the principles that come up out of spirituality, things like being mindful or clarifying your values. So lots of spiritual practices actually help clarify values. Those things we know do help. People who have a sense of community, especially, that is often comes along with spiritual or religious practice, also benefit from that social network and having that support. So those kinds of things we know are beneficial to health in general. I haven't seen any specific studies, but we would anticipate that it would be beneficial also.
Okay, thank you. This is a question for Dr. Wharton. What has been your real-life experience with long-term management with anti-obesity medications? And do patients stay on the medications? And importantly, how long should they stay on the medication?
Terrific question. So I'd said that I often get the question as to how much weight am I going to lose? That's not a question that I get really all that often. People are just happy that there is something available to help them to go down. They're not always focused on how much. What they are focused on is how long. That's the number one question. How long do I have to be on this medication? Number one question before side effects, before cost. How long do I have to be on the medication? Again, that's part of the bias. The bias is I don't need medication. I don't need something over and above. But my answer to them is always, I don't know. I have no idea how long you need to be on this medication. What I do know is how long you will live with obesity, and that's forever. It's never going to end. So therefore, if you're not maintaining the lower calories and the self-esteem and the better value system with one of the pillars, you're not going to be successful. So if your intention is to be on the medication for a short period of time, then you better use another pillar to be able to maintain that weight management. So shift over to cognitive behavioral therapy. What is the value-based therapy? Why are you waking up at 6 o'clock in the morning? The medication does not help you wake up at 6 o'clock in the morning to go exercise. A value does. I want to be around for my grandkids. That allows me to wake up at 6 o'clock in the morning to go exercise. Without that, it's a big challenge. So you've got to ask those questions and get to that level. Otherwise, the person is going to end up falling down. What's my experience with long-term management with the medications? Everybody plateaus, and almost everybody regains weight. So that's the natural progress of our bodies, of our brain, of the physiology. Every single clinical trial has showed it, and every one of my patients show it. So the question is, when the weight plateaus and you're not at a stage you'd like to be because your knees still hurt, et cetera, can we add something else on, i.e. second medication, medication number one, medication number two, more cognitive behavioral therapy, or cognitive behavioral therapy, period, because they didn't understand it, didn't believe in it, and now they're getting it. So that's what I do when people plateau or they start to go back up, which is always. They always plateau or start to go back up because that's the natural physiology of our bodies.
Okay, another question for both Sandra and Dayna. What are some of the specific CPD tactics that you can use to reduce cravings?
So I have a little 3-step process that I use. The first thing is I identify a craving as a lie. It is always a lie. It's this little voice that says, you know what? Today you can have one cookie and put the box away. It's totally different, even though I know thousands of times it's never been that way, but today will be different. Or that voice will say, you know what, today was too hard, too stressful, people just upset you too much, you should definitely have this. So the first thing is I really call it out as a lie, so I don't start negotiating with that voice or starting to believe that voice. And then I try to observe the craving. I try to observe it like a wave, and a wave doesn't last forever. And I try to understand what's happening in my brain, and am I feeling super stressed in this moment? Have I been triggered by a cue? Have I maybe looked at the dessert table too long and my dopamine's hit an all-time high? And lastly, that I find is immediate and available to me is I take 3 deep, deep cleansing breaths. And what that does for me is it grounds me, it really oxygenates my brain, it helps me make a better decision. And for me, cravings sometimes bring about anxiety because I'm not actually sure what I'm going to do. And so those breaths also help mitigate some of that anxiety.
So I love presenting with Sandra because she basically says all the things I need to say in a really lovely way. So the way that we, encourage people to deal with cravings is to identify that they're a wave, right? We have a relationship with cravings where we think they're going to go on forever until we give into them. And so we actually teach people how to ride that wave, the wave of discomfort, right? We're not expecting it to feel good. We're just trying to be willing to have it feel not good in the service of something that matters to you. And so all of the strategies that Sandra mentioned help with that. There's part of what Sandra described there is sort of this mindfulness, right, of noticing what's going on. And also we want to help people have this sort of observer position. So if you imagine like a hurricane, right, coverage of a hurricane, there'll be the reporter down on the ground, like being thrown around in the wind and the rain. And then you go to the announcer, and he's like, well, you can see from the southerly direction of the wind, right? It's the same event. The difference is the perspective. One of them is caught up in it, and the other one is observing it. It's like that satellite position. And basically, when people can get to that satellite position, they're less influenced by some of these thoughts and feelings that have been motivating them before, right? And they're usually caveman motivations that, again, would be awesome if you were a caveman, but probably not so useful in our modern world. And so to teach that ability, which is one of the things that you learn through mindfulness, to get to that satellite observer position so you can watch the wave rather than being thrown around in it. So, and we did a 3-hour workshop yesterday answering this question also, so that's my brief answer.
Question for both of you. Does mindfulness help to increase cortical function?
We don't have the neuroscience person here. What we know from studies of mindfulness, so mindfulness is one of those things that if you do it regularly, it just makes you healthier in like every domain. It's helped with, cancer, it helps with depression, it helps with anxiety. It's one of those things that if you actually do it regularly, it helps with everything. And what we know is that for people who do that a lot, so for example, if you do studies of Buddhist monks who meditate a lot, that you actually do see differences in their brain functions and what areas light up in their brain when they're really well trained in being able to do that. And so it also helps sort of activate your frontal lobe, right? So the frontal lobe always requires deliberate, conscious effort. And so that mindfulness is really key to be able to activate that frontal lobe. All the other kind of instinctive things that show up, those primal instincts, caveman brain stuff, that just shows up automatically. You don't have to do anything. It's just going to be there. So trying to activate your frontal lobe requires this ability of mindfulness to be conscious and deliberate.
So a question for Dr. Wharton. How long should patients be on medication to figure out whether the drugs are working or not?
Terrific, yeah. So that's a good question. So a little bit of background so in terms of weight management, you have about 6 months on a medication or a lifestyle treatment to lose weight. Once you get to that 6-month time frame, you end up plateauing. We don't see much weight loss past the 6-month time frame, except for bariatric surgery where we go to a year and a half. So it is important to try to understand how you can get that weight down in that time frame. And we don't exactly know why you stop at the 6-month time frame. Maybe it's the brain decides, I don't like this weight loss, regardless of whatever you happen to be doing, and I'm going to use other mechanism to actually stop it. So while you're tricking the brain, try to get as much weight down as you possibly can. So therefore, many people will start to feel I'm not feeling the hunger, I'm feeling more calm, my brain is calmed down within a couple of weeks. Within 2 to 3 weeks, you should start to feel something different. So the behavior, the change in your brain functioning, the ability to waken up the frontal lobe, and the frontal lobe now has more function over the body, over the cravings. That should happen. And then that ends up resulting in the eventual weight change, which is different for every person. So don't gear it just on the weight. We try to not ask, how are you doing with your weight with this medication? We ask, how are you feeling? What has changed? Has your hunger changed? Has your level of control changed? Has the noise decreased? If that's happening, the likelihood that your weight management is going to go well is very good.
Thank you. Question is for Dayna. Can you explain the value of validating versus invalidating your client's emotions?
Sure, yeah. So, we often do this thing. So for example, somebody comes in and says, it's really bad. And our natural instinctive response is say, no, it's not that bad, all right? And what that forces the person to do is to justify why they're feeling that way. So then they have to up the ante. No, you clearly don't understand. This is really bad. And then again, we're trying to make them feel better. So we respond, no, it's not gonna be that bad. It's gonna be okay. Everything's gonna be fine. So now the person is again forced into this position of having to justify themselves. No, you clearly don't understand what a catastrophe this is. This is a huge, big problem, right? And this is actually just our normal response, right? So validating somebody, you don't have to validate their beliefs. You can validate their experience. So if I have, a patient who comes in and says, oh, I'm so upset, like all the doctors in the dialysis unit, they hate me, right? I can validate his experience, like, wow, that must feel really hard to, feel like everybody hates you, without validating his belief. I don't have to say, you're right, they totally hate you. Right? I don't have to validate the belief to validate the experience. And validating the experience is just acknowledging that is what you feel. It's not about whether it's right or wrong, not at why do you feel that way, it just is. That's how you're feeling. And to try and sort of get into their shoes of understanding what that's like. When people feel validated and they feel heard and understood, they are much more likely to then change, right? So once they feel like somebody has got them, that they really understand it, they're much more likely then to problem solve differently, to brainstorm differently, to be more able to make different choices.
Okay, thank you. So this question is for Dr. Wharton. Weight management medications are quite expensive. So how do you help people who have difficulty accessing those medications?
Very good question. I think this is a bigger question. This is like a socioeconomic question, like how do we help with poverty or how do we help with those? I think advocacy is the most important. I think that the patients that are being harmed by it, the physicians that are feeling helpless because their toolbox is without tools for their patients that don't have coverage, need to advocate a lot louder about what we just spoke about, the pathophysiology. The fact that the brain lights up and it's difficult to calm it down even when someone's working really hard. Once you understand the pathophysiology, that, which we can explain to patients, then the person who's working at the insurance company, the government structures, the other family physicians, the actual patients themselves will start to realize that this medication is needed. So that's where I believe we need to go. We need people to understand what the problem is, and we're getting closer to understanding what the problem is. And Sandra's shared that with the way that even as she's doing well, a food addiction counselor, working with it on a daily basis, waking up that frontal lobe to the point that she can answer questions about how to wake up your frontal lobe, to the point that those lit up areas haven't gone away. Therefore, pharmacotherapy, she's now using to calm that down so that the army can be a lot better at actually fighting it. That pathophysiology needs to be explained, therefore we'll get access to the medications.
Thank you very much. So the time is almost up, so I'm gonna perhaps challenge you in terms of what you can do things differently tomorrow morning. So here are some of the messages that I've learned from the expert panel today. Number one, recognizing that eating behaviors are regulated centrally in the brain, driven by the homeostatic and hedonic eating, and of course, the frontal lobe, which is really where the executive function of the brain resides. Consider that in combination with healthy behavior modification, pharmacotherapy, and in selected individuals, bariatric surgery can certainly help people to achieve and maintain clinically relevant weight loss by controlling health behaviors, appetite, activities, and so on. And remember, just like what Sandra told us, it takes a village, an interdisciplinary team of healthcare professionals to help manage obesity effectively by helping our patients to set goals, linking them to the values, and by being kind and compassionate and clearly non-judgmental. So on this note, I'd like to thank you all for coming to this symposium, and importantly, I'd like to thank all the speakers as well as Dr. McIntyre, who's unable to join us in person, and I certainly hope that you've take away some of these very important learnings that at least I've learned at this symposium. So please fill out the evaluation form. And on this note, thank you very much again for joining us for the Luncheon Symposium. And enjoy the rest of the Obesity Canada Conference.